Welcome to SARC Talk. SARC is a nonprofit cancer research organization that develops and manages clinical research trials in pediatric and adult sarcomas. SARC Talk is a podcast to discuss activities of SARC, interview sarcoma research leaders, and review scientific initiatives in the sarcoma field.
Welcome to SARC Talk, episode number 10. My name is Scott Okuno, a medical oncologist at Mayo Clinic and Chief Medical Officer of SARC. All episodes are posted on our website, Spotify, YouTube, SARC channel, or wherever podcasts are available. Please subscribe and submit comments because this is very helpful for us. Our guest today on SARC Talk is Dr. Jonathan Trent, Professor of Medicine at the University of Miami at the Sylvester Cancer Center and Director of the Sarcoma Medicine Research Program. Dr. Trent is an internationally recognized sarcoma expert and is very active in patient advocacy and social media. Today we'll be discussing a rare sarcoma histology called PEComa. Welcome, Dr. Trent.
It's great to be here, Scott. Thanks for inviting me.
No, we appreciate it, and we thought it'd be worthwhile to kind of focus a little bit more on a rare histology, and since you have expertise in this area, you can share not only what you know for us as clinicians and oncology providers, but also for patients and their families. So before doing that, John, you did your oncology training so people get a little understanding of where your training was. You did your training at MD Anderson, where you were actually on staff there, and then you moved to your present position in May of 2013. That's a long time ago.
It was actually 2011.
2011. So it's even longer than that. That seems just like an eternity from what I remember. But can you share with our audience how your training prepared you for your move and how have things turned out in the last 12, 13 years?
Yeah, thank you again for the kind invitation, and thanks for allowing me to discuss PEComa, which is a rare type of sarcoma, but increasingly important to understand. And so how did I get where I am today is a great question. And so I was on faculty at MD Anderson for about 9 years, and I felt like I had a very good understanding of sarcomas as a medical oncologist. Certainly, we still learn new things about these rare diseases every day, but I felt like I had a pretty good understanding. And I was giving a presentation, a grand rounds presentation at Sylvester Comprehensive Cancer Center in Miami, and they were starting to look at building a sarcoma program. So that kind of just got my brain thinking about it. And then a few months went by and I realized I was seeing a lot of patients from South Florida. I probably at that time had about 20 patients in my practice from South Florida who were flying to see me every 3 or 4 weeks. And that led me to look into it. And really in South Florida at the time, a metropolitan area of 6 million people, there was not a sarcoma center like at Mayo Clinic or Dana-Farber or MD Anderson, a center where there was multidisciplinary expertise. And I felt like it would be a good opportunity for me to build a sarcoma program so that these people, these 6 million people that live in South Florida, don't have to fly all over the country for sarcoma expertise. And Sylvester had already recruited Andrew Rosenberg, which, as you know, he's a sarcoma expert pathologist. And as you know, that's really the key fundamental to any treatment that we prescribe, is understanding the diagnosis with the best certainty that we can. And so that's how I ended up at Sylvester. It's been an incredibly supportive environment. Our director, Stephen Neimer, is a great role model and mentor for me. And so it's worked out well.
I know, John, you've been actively involved in the Cancer Center Renewal Grant or getting comprehensive cancer status, and I know that was a lot of work. So you've had a fun time developing programs, not only in the Sarcoma Center there, but also in your Sylvester Cancer wearing your hat. So it's great. In addition to yourself, I do know you do have colleagues in medical oncology as well, and I think having a variety of input does help out. Can you describe how your team is down at MD Anderson? I mean, from how it's the same or different from MD Anderson to now at Sylvester, because you're building out that as well, your medical oncology part.
The first thing was seeing patients, of course, delivering patient care. And so we've been building on that. And when the year before I arrived here, Sylvester saw 62 new sarcoma patients. Last year, we saw 903 new sarcoma patients. So it was clearly a need in this area of the country. And that growth has allowed us to grow our multidisciplinary team. We have Gina D'Amato and Emily Johnzak, and just this summer hired a fourth medical oncologist, Steve Bialik, and also hired another surgical oncologist, an orthopedic oncologist starting this October, this month, hired an additional sarcoma pathologist, and hired another radiation oncologist, Crystal Selden, who is focusing specifically on sarcoma.
So for those that are keeping track, it started with one, they're up to four, and they're building out the multidisciplinary team. Even the pathology group has grown. So this is a great place to go visit. So if you have an opportunity to see the Sylvester Cancer Center, it's a nice, beautiful place, and it's a great place to get care and expertise. So today we're really going to focus on one of the 70 soft tissue, up to 100 different soft tissue histologies. And Dr. Trent, maybe you can describe what is a PEComa?
Good question. And I remember to this day, the first PEComa patient I saw. I was maybe second year faculty, and I said to myself, what the heck is this? And Andy Burgess said, oh, it used to be a sugar tumor. Now it's a PEComa. And so it's a perivascular epithelioid cell sarcoma or neoplasm. And it's actually a family of rare mesenchymal tumors that are composed of malignant cells that have the morphology and immunohistochemistry pattern of these perivascular epithelioid cells. That's where the PEC comes from. That's what normal tissue the tumor looks like. These these were first described really not that long ago in the 1990s. PEComa was described, and mostly in the lung and in the kidney, and now the WHO recognizes it along with 174 other sarcoma types as a mesenchymal tumor composed of histologically and immunohistochemically distinct perivascular epithelioid cells. So that's really a pathologic diagnosis. And that helps us and underscores the importance of pathology, because this is a very specific diagnosis, and the diagnosis impacts patient outcome and treatment selection. And so, PEComas can really arise almost as a primary tumor, arise almost anywhere in the body. The most common sites are retroperitoneum and uterine. And the uterine primary is why there's more women than men diagnosed with PEComa. The metastatic sites include the peritoneal cavity as a very common site, and liver, and even lung, and other rare sites. PEComa is also distinct in that it often has a specific mutation, an alteration in a gene called TSC1 or TSC2. These inactivations of the gene lead to hyperactivation of the mTor pathway. And the mTor pathway is a signaling pathway that transduces the signal through different kinases into the nucleus, phosphorylates phos and Jun and other proteins to really drive transcription of the genes and proteins that are responsible for the tumor phenotype. And that's how an individual presumably ends up developing a PEComa is that there is a cell in their body, whether it's a perivascular epithelioid cell or not, that develops a mutation in TSC1 or 2 or some other way to activate the mTOR pathway. It's really the key to tumorigenesis here.
Jonathan, you did bring up the point that there's a lot of biology that has gone into just the mechanism of how PEComas grow and develop, and more importantly, just to get the diagnosis. You know, when you said you started out with 62 patients a year up to over 900, probably going to eclipse 1,000 this year, what other sarcomas in your experience are often diagnosed, but when pathology is reviewed, turns out to be a PEComa and vice versa? Because a lot of us in the community want to know, like, when should I think of PEComa? Or when someone says it's a PEComa, it ain't a PEComa. So kind of some pearls of wisdom that you've kind of picked up along the way on making sure that what are some of the scenarios where misdiagnosed or often diagnosed as something different when it truly is a PEComa?
Yeah, that's a great question, Scott. And I know that you face this in your practice too, there at Mayo. We see patients with a diagnosis in the community, and then the pathology material is referred to a sarcoma expert. And it turns out the diagnosis has changed in a meaningful way about 20% of the time. And I suspect it's pretty similar for PEComa. We see patients diagnosed with leiomyosarcoma of the uterus, and sometimes it ends up being a PEComa. We see patients with PEComa, and sometimes it ends up being leiomyosarcoma. I'm not faulting community pathologists, because I think it's very, very rare. I mean, it's clearly very, very rare. And it's also a challenging diagnosis because PEComas often have smooth muscle features as well. And so we've seen the diagnosis change from leiomyosarcoma, endometrial stromal sarcoma is another one that we see sometimes, myxofibrosarcoma may be another one. This is unusual, but I did see a gastrointestinal stromal tumor diagnosed initially as a PEComa in the retroperitoneum. Those would be the ones I've seen at least recently. And, sometimes our pathologists struggle with this diagnosis. It's an unusual tumor, and it can have smooth muscle, but also melanocytic markers. And so it's, even in the pathology world, with the sarcoma experts, I've seen it be challenging a number of times. Sometimes we turn to NGS. I don't know what you do, Scott, when you're struggling between, is this a PEComa or a leiomyosarcoma? They can both express estrogen receptor, so that doesn't always help. So we'll look at NGS and see if we can find a pattern in NGS that supports PEComa over leiomyosarcoma, such as TSC1 or TSC2 biallelic inactivations or other alterations. Not to say that a leiomyosarcoma couldn't have that mutation, but when you're trying to make the best decision you can, sometimes NGS can help.
No, you're correct. And for those that are listening, next-gen sequencing is what we're talking about, molecular targeting of the tumor, specifically at the somatic mutations or the mutations specifically in the tumor. All of a sudden, anybody walking around with leiomyosarcoma, melanoma, gastrointestinal stromal tumor, you really want to make sure they don't have PEComa, and vice versa. Everybody walking around with PEComa, you want to make sure they actually have PEComa and not some other histology. And as you said earlier on, when you first started, you made sure that you had a pathologist that had expertise, and even with that, there could be I'd say interpretations as you move along, and now you're bringing a second pathologist on, as you said. So how does pathology review typically occur at Sylvester, and kind of share how that process works?
Yeah, that's a great question. And as we've discussed, it's really the foundation of our care for patients, is understanding the underlying diagnosis that the patient has, not only in terms of what type of sarcoma this entity is, whether it's a PEComa or a leiomyosarcoma, but also how indolent or aggressive it is. And this is particularly important in PEComa because there can be non-malignant PEComa, there can be malignant PEComa, and the pathologists help us understand how aggressive an individual patient's tumor may be through the way they grade the tumor, but also from their experience. And so that provides us a lot of input. So at Sylvester, we require all patients to have their pathology reviewed by us. The 3 sarcoma pathologists are Andrew Rosenberg, Liz Montgomery, and J. Lou Velez. And so one of the 3 is required to, we require review of the pathology before we make final treatment recommendations. Even if a patient has an outside consult at an expert center, a lot of times that consultant has one tiny little piece of tissue that's as thin as a hair, and they don't get the full history. They don't get to review the imaging at tumor board. And so I think most of us at sarcoma centers require internal review and discussion at tumor board so that we have a consensus diagnosis. And so we require that for every patient. And then we have a sarcoma team meeting every Friday, and we review all of the new sarcoma patients for the next week. And we go over imaging and pathology, and we hash out a consensus game plan to give the patient the optimal recommendations, realizing that some things may change after one of our sarcoma oncologists meets with the patient. They may learn new information, but we think it's a good starting point to help with early multidisciplinary recommendations and really present a data-driven, uniform approach.
I'm just going to unpack a few things here because what you said is very key. And I think if you're paying attention, I think some of our patients, when they come to academic centers, want to just get in. But as you're hearing from Dr. Trent and other people, and even us and Memorial, MD Anderson, and other major sarcoma centers, they require pathology because everything hinges on pathology. And sometimes coming early and getting something changed 20% at a time is not worth your effort because then it's a rediscussion. So it does take time to get the pathology reviewed. It also takes time to get people scheduled. And even if you want to do next-gen sequencing, that's about a 10 to 14-day turnaround. So you can imagine the anxiety that we experience as treating oncologists, that we're waiting and waiting, but sometimes we have to wait because treatment is predicated on that. You bring up the point, Dr. Trent, too, that it's important that the biopsy is reviewed, even though you might get a small little piece. When you go to these multidisciplinary clinics and tumor boards, you have imaging input from different people. Can you share how that plays out? I know you said you do it every Friday and get things teed up, but this, I think, for other people that are listening, how the importance of having these sarcoma conferences are, and that might highlight what we do here at Sark as well, because we have a monthly international or national tumor board as well. So, John, can you describe just a little bit more detail of what the actual physical process is of your tumor board, so I can learn from what you guys do and then other people as well?
Yeah, so we have 2 tumor boards a week. We have a Tuesday tumor board, Thursday tumor board, 4 to 5 p.m. so that people are not staying too late, especially if they have small kids or other commitments after. We don't want to be doing tumor board 7 to 8 p.m. That's just, not healthy for anybody. So we do 4 to 5. And we usually, Tuesday, we focus mostly on bone and orthopedic oncology sarcomas, although there's overlap and we do see soft tissue on Tuesday also. And then Thursday, we focus on the soft tissue retroperitoneal, GI, soft tissue sarcomas, but we also have orthopedic oncologists at that one also. So it's a little bit of a mix, but we may have 6 to 8 patients on Tuesday, and maybe 10 to 12 patients on Thursday. And I think that just reflects the incidence and the prevalence of the different types of sarcomas. And then and they're multidisciplinary. And I don't know about you guys at Mayo, Scott, but the Zoom has been very helpful in increasing attendance at Tumor Board and other platforms too, I'm sure. And so we may have 30 or 40 attendees at Tumor Board. If the patient has a external oncologist, we can even we've figured out a way to have them join the Zoom as well. And so I think that the being able to virtually do Tumor Board has been very helpful in some situations. And our Tumor Board is mostly patients being presented who have multidisciplinary discussion. If it's a question about chemotherapy, we have a different venue for that. If it's just radiation, then it would just be a radiation oncology consult. But these are really patients who, they might need radiation, they might need surgery, they might need chemotherapy. What sequence do we want to do these in, and really hash it out there so the patient can get a roadmap for their treatment all at one time rather than sequentially.
And I think what you're describing, it sounds very similar to us. We have very similar, several times a week, we do have the same type of thing. And I think Zoom has definitely helped out, because we do ours at Thursday evenings at 5:15 to 6:15, and the surgeons are still operating, so they can come out of the cases and help out as they go along. But it does help out, and getting that input is critical. We do provide food to entice people to come to that, but some people, because of logistics, are doing it from not in the office there or in the conference room. So you can see, as we start to build out, as people are looking at major cancer centers, this is the value of being a clinician oncologist at a major sarcoma center. And then you see the multidisciplinary continued opportunity to see what your colleagues are doing and hear what other people are doing within your group and elsewhere. So as we start to go into the PEComa realm, a lot of times these individuals do present with local disease. Can you describe generally what is your approach for localized disease based on staging studies, and how do you approach them?
Yeah, that's another great question, and it's a challenging situation. I would say probably 80% of the PEComa patients that we see at our center are locally advanced or metastatic. And they've already had surgery oftentimes. They may have had a piecemeal surgery, or, this didn't know, the diagnosis wasn't clear, and not quite the right surgery was done. But for the local therapy options, generally would be surgical. So the primary sites are retroperitoneal, certainly uterine, kidney, GI. Those are the common sites. And surgery would be the mainstay of therapy at our center. If there was, for instance, a patient that had comorbidities and wasn't able to have surgery, then we might consider definitive radiation therapy in that setting, depending on the anatomic location and the risks involved with that. But generally, surgery would be the primary treatment for a patient with a localized PEComa.
We always say that the most important surgery is the first surgery, to make sure that you get it all out, but it's still an oncological surgical approach that most of us would think about if it's localized disease. And I think that's important. And I think, when it's local, we're going for a cure. When 80% of your patients, you said, are more advanced disease, peritoneal spread or distant metastatic disease. And then it comes back to our realm in the form of a medical oncology or drug therapy approach. And maybe we'd like to hear kind of your sequence of systemic option or drug options that we have available, and then we can get into the details of the specifics. But just in general, how do you approach systemic therapy?
Yeah, another great question, and this is important for many, if not most, patients with a PEComa at some point. And metastatic disease is not, at that point, is not cured by localized therapy, surgery, radiation, interventional procedures. So discussion with a medical oncologist would be the next appropriate step. And so when we see patients at Sylvester, we generally discuss all of the options for systemic therapy. The typical options that we think are most effective are either a targeted therapy or a chemotherapy. Targeted therapy meaning an inhibitor of the mTor pathway. And there's a number of them out there. And chemotherapy, the two agents that have been studied the most have been doxorubicin and gemcitabine. And so those are the two that we discuss with the patients. And we discuss some of the data and the benefits and risks of each.
So if you're given a situation and they have kind of a very indolent disease, not really spreading too much fast, and you can kind of get an idea the pace is not that fast, is there an option for just close observation, or is there more sense that no, it's there, it's going to cause problem, probably a little bit earlier intervention makes sense? So how do you approach that?
I agree 100%. There are, PEComa is one of those sarcomas where there's a very broad spectrum from indolent to aggressive. And the indolent tumors, like you mentioned, they can change, a millimeter maybe or two every 3 to 6 months. In that situation, there's no urgency to initiate chemotherapy, but you still have to keep a close eye on patients because the biology can change along the way. But observation for an indolent PEComa or one that doesn't have malignant features is definitely maybe the best therapy.
So now our patient comes into the clinic down in Miami and says, this disease is growing. It's growing and causing problems and needs drug therapy. How do you choose or help guide people between mTOR inhibition versus cytotoxic chemo, as you said?
With mTOR inhibitors, so we share with the patient our interpretation of the published literature in terms of the probability helping the patient with the mTOR inhibitors and with chemotherapy. And so with mTOR inhibitors, the chance of shrinking a tumor is at least 41%. Controlling it, is 70 to 80%. And so that typically sounds a lot better to patients than traditional chemotherapy, where the response rates are anywhere from 10 to 20%, and the progression-free survival is about 3 months on median. So, and then you discuss side effects from chemotherapy versus targeted therapy. And most patients are interested in targeted therapy with an mTOR inhibitor over chemotherapy based on the higher response rate and less severe. There can be a lot of toxicity with mTOR inhibitors, but in general, it's less likely to be life-threatening, like neutropenic fever, etc.
So I think you're probably spot on. I think most of us have given our choices based on the data like you shared. mTOR inhibition does make sense for a lot of our patients that need treatment. There are a lot of different mTOR inhibitions. Some are pills, some are IV, and we have other drugs that are available. And John, can you kind of go through the different mTOR inhibition drugs that are available and kind of highlight some of the nuances between each of them and kind of how you select which one you decide to use if you decide to use an mTOR inhibitor.
Yeah, so with most of our patients, frontline therapy, I would say the majority of almost all metastatic PEComa patients, our frontline therapy is an mTOR inhibitor. And the mTOR inhibitor of choice in our institution is nab-sirolimus. And that's basically, it's albumin modified sirolimus. And, there's lots of preclinical data showing increased delivery to the tumor cells. But the bottom line is that we all participated in the AMPECT study. And for PEComa patients, and the objective response rate was right around 40%. Also, disease control rate was just over 70%. But importantly, the median duration of response in the MPECT study was 40 months. Scott, that's like almost 4 years, right? And so we generally recommend that one first. The other mTOR inhibitors are also on NCCN, and we have been able to use them in the past. And so we often use everolimus. Everolimus is an oral agent that can be taken daily. I've also used temsirolimus in the past. It's a little, it's an IV agent, and so it's a little bit different, but also effective. I think they can all be effective.
You bring up the point there that many of us before the NAB sirolimus, we had to use sirolimus, the pill. We had to use everolimus, because that's a pill. We had to use temsirolimus because that's all we had. But based on the trials, as you said, I think most centers are now basically pivoting to nab-sirolimus. For those that are community oncologists, because it's very indicated for one disease right now, can you share a little bit of what you should look forward to in monitoring toxicity and how you guys manage that at Sylvester?
Yeah, I think that managing the toxicity is something that's really, really important. And our approach, not all sarcoma centers are this way, but our approach for most agents that we use is we try to preserve the recommended dose, or try to provide the patient with close to the recommended dose in terms of their tolerability. And so in order to preserve dose intensity, we generally focus very aggressively on the toxicity and try to manage the toxicity rather than lower the dose. It's much easier to lower the dose, but from our experience, that doesn't always decrease or get rid of the toxicity. Sometimes you can get more bang for your buck by addressing the toxicity with a supportive care medicine. And so, for instance, some patients with some of these oral, particularly mTOR inhibitors, may have diarrhea as a side effect. And so they may take their sirolimus or their everolimus, they may take that at 8 a.m., and then they get diarrhea at 10 a.m. every day. And so they get an Imodium package, and the Imodium says, take after each loose stool. And so that's really designed for infectious diarrhea and not really for a chronic diarrhea that's therapy related. So we talk to the patient and we say, take your Imodium, 1 or 2, at the same time you take your oral therapy. And this way you have a preventive measure in place to actually prevent the diarrhea, which lowering the dose by 20% may not really prevent the diarrhea. It might make it a little bit better, but Imodium or Lamodal or even tincture of opium is very, very effective at controlling diarrhea. And the same for some of the other side effects. With some of these agents, we do see stomatitis or mouth sores. These can be a little challenging to manage. I'd be interested to hear what you guys do at your site, Scott, but we may use salt and soda mouthwashes a couple of times a day to try to prevent it. We may use some type of biogels or artificial saliva rinses. We may, if it's the IV injection, we may have the patient drink cold liquid or ice around the IV infusion of the nab-sirolimus or other. And so we try to manage the side effects as best as we can. If you have to lower the dose, you have to lower the dose.
No, we agree. Appropriate oral care is a huge thing, and it's the cheapest thing in the world. Saline soda rinses, it makes a huge difference. If it's really bad, we'll do the cryotherapy, as you said, during the infusion, and whether it works or not, we'll see. And it's a nice way to get good stability because you're looking at people out years potentially on the drug. So you have to figure out a way for them to continue to be maintained in quality getting the treatment. So that's good. We occasionally will have a situation where it's a big tumor. They want to shrink before taking it out, or they took it out and says, geez, I think it's going to come back. How do you approach the use of these therapies on a neoadjuvant or an adjuvant basis? Because the studies were done with advanced disease, but just like to hear your thoughts on neoadjuvant or adjuvant therapy for, let's say, big, large, high-risk PEComas.
Yeah, that's another situation that's a challenge. And with a 40% objective response rate with nab-sirolimus and the other agents, then that kind of begs the question whether there shouldn't be a study, a neoadjuvant study or adjuvant study, possibly through this very effective organization called SARC. And so it would be a great SARC trial. But we don't have data in adjuvant settings, so we tend not to give nab-sirolimus or other mTOR inhibitors in the adjuvant setting. If a locally advanced patient is presented at conference and we decide on neoadjuvant therapy, we would consider that if the patient's not resectable and there is an opportunity to downstage the tumor, learn about the chemosensitivity of the individual tumor cells, treat micrometastatic disease. We might take advantage of that in the neoadjuvant setting, where we can measure the tumor and determine whether we're helping the patient. In the adjuvant setting, it's just a lot more challenging to know whether or not you're helping the patient, and they could have some side effects that maybe they should have or shouldn't have. You don't know because you don't have measurable disease.
No, I think as people that are listening to this or other groups out there, I think what you describe is consistent. Neoadjuvant, if it's marginally resectable, but really no proof that adjuvant therapy makes a difference. But that might be a research study that we can do. So in this area of PEComa, where do you see we are in the next 5 years? Because we're very fortunate to have a drug now that's overall well tolerated with great clinical benefit rate. We have a good response rate, overall well tolerated in general. Where do you see us going?
Well, I applaud the question, and I hope that we do go somewhere because this is an exciting drug that's been needed for a long time for patients with PEComa in terms of nab-sirolimus and the other mTOR inhibitors. But I would really like to see an adjuvant or neoadjuvant study. Neoadjuvant studies, you can learn some about the biology when you're comparing pre-treatment biopsies with post-operative specimens. But in our practice, that's a more rare situation and than seeing the patient after they've already had surgery is a much more common situation in our practice. And that might be regional, but I think a national or international study exploring neoadjuvant plus minus adjuvant nab-sirolimus and localized PEComa would be a fabulous study, and I think would save lives. Now, in the metastatic setting, first thing that comes to mind are combinations. We know nab-sirolimus has a 40% objective response rate. Gemcitabine has a 20% objective response rate. Should they be combined? Maybe. Not that exciting of a study, but who knows? There may be synergy there. Anthracycline response rates are less, but could be an opportunity for a combination there. There's some cytopenia with nab-sirolimus, but not marked cytopenia like with chemotherapy. So they might be well-tolerated combinations. And then thinking outside of the box from what's known and looking at the mechanism of action, thinking about maybe DNA repair pathways, combining nab-sirolimus with a PARP inhibitor might be exciting. We know that there are some DDR pathways that are activated in PEComas. What about immunotherapy? We know very little about that in PEComa. And then the last thing I would like to touch on is that in the AMPECT trial, there was a waterfall plot showing the responses by mutation. And there were patients with TSC1 and TSC2 mutation that responded. And then there were some patients that didn't have TSC1 or TSC2 mutation who responded to nab-sirolimus in a meaningful way. And so what is the mechanism of non-TSC response to nab-sirolimus that could open the door for other treatment pathways?
That was highlighted as well, and I think you are right. And I think anybody listening, we have about 5 different trials that we can do in people who've progressed on nab-sirolimus. But you bring up the point that TSC1 and 2 are often mutated or involved, and patients do respond with those, but they also respond to non-TSC1 and 2. Patients do come asking, is this hereditary, and should I have a germline evaluation of, TSC1 and 2, and because there are the hereditaries, and I don't know how you approach it and whether or not genetic counselors are involved in the assessment of all your PEComa patients.
Yeah, I would say in the vast number of PEComa patients I've seen in my career, hereditary syndrome is very rare. I in the single-digit percentages for sure, and so but it could happen. There could be a hereditary syndrome. So you especially in the setting of a tuberous sclerosis complex syndrome. So we look at, there's some physical signs associated with TSC syndrome. There's also the early age of onset. Could be a family history. If there's a family history of PEComa, that would make me start thinking about calling my local medical geneticist. But basically, if a patient is interested and concerned, we have a low threshold to refer to medical genetics and do the hereditary testing, just because if nothing else, it'll put their mind at rest and help with anxiety, especially if they have small kids or some relatives.
I agree, because most of these TSC1 and 2 are somatic, but as you said, unless you pay attention to all the syndromes out there, we have to kind of be a consummate internist and trying to make sure we take care of the patient, all the other stuff, and then also siblings and children, as you said. So there's a lot more that we could spend on PEComa. As you know, it's an extremely rare tumor. I think I'd be remiss if I didn't ask you, most of the sarcoma centers are now seeing patients who have been treated or previously treated with nab-sirolimus. So short of the clinical trial options that you thought about in designing that we can talk about Sark or other agencies to do that, how do you approach real progressive disease where systemic therapy is needed in patients with a PEComa that have had nab-sirolimus already?
Other than a clinical trial, standard agents could include gemcitabine alone or with docetaxel. And again, there's a 20% objective response rate in the historical literature, so it's not an unreasonable option. That's as high or higher than it is in soft tissue sarcomas in general, and we do use GemTax all the time. So that's reasonable. Doxorubicin-based regimens are also reasonable, but associated with more toxicity. But oftentimes we re-challenge with nab-sirolimus, or we challenge with a different mTOR inhibitor, for which maybe you have better pharmacokinetics, or maybe it's binding in a different region, or maybe it's not susceptible to the mechanisms of resistance, such as export pumps within the tumor cell. So we'll often try a different mTOR inhibitor in patients that have progressed on nab-sirolimus, everolimus, temsirolimus, and also we've used sirolimus a few times by itself after progression on nab-sirolimus with some efficacy.
Sounds like what you're doing is what most sarcoma centers are doing, either re-challenge with a different formulation of sirolimus, as you said, or if they need treatment, go to cytotoxic. Clearly a space that we do need more work on in clinical trials, and as you said, ultimately enroll in a clinical trial at this point. So, Dr. Trent, we've gone through a lot, gone from the diagnosis, kind of what you do at your center there, kind of what you do in systemic therapy, what you kind of do in relapse situations there. We do appreciate you sharing your time and expertise with us and the sarcoma community to discuss PEComa. Any additional thoughts or comments that you have for us?
No, I would just like to thank you for you and Sark for educational events such as this podcast. I think that the sarcoma medical oncology community can, through this podcast and other mechanisms, can reach a lot of community oncologists, a lot of patients through social media and through this type of media in order to make sure patients are getting the optimal care possible. I'd like to thank Sark for their clinical trials. That's key. And in PEComa specifically, we need to collaborate. We need to be doing tissue studies collaboratively and doing clinical trials like some of the ones we discussed today to continue to advance the field for our patients with PEComa.
Absolutely. Well, Jonathan, Dr. Trent, thank you for, continue to be an advocate and supporter of SARC. I know it's an important aspect, and as we continue to evolve and grow at SARC, clinical trials in this space is going to be needed for these rare and ultra rare tumors. So thank you. Thank you for spending time with us.
Thank you.
For those here, please share SARC Talk with those that are interested in sarcoma. Please leave comments and suggestions about our SARC Talk podcast, and we'll address them at our next SARC Talk. So thank you all.
Thank you for listening. Be sure to subscribe so you never miss a SARC Talk. To find out more about SARC, please visit our website at sarctrials.org. To suggest a topic or for questions, please email us at sarctalk@sarctrials.org. The SARC Talk series is made possible due to funding from Adi Biosciences. Together, we can find a cure for all forms of sarcoma.